So you can just arrow through when you're shooting.
Okay, thanks.
Okay. We're ready to go.
Hello, everyone. I'm going to go ahead and get started. My name is Jamie Stutz. I'm the co-leader of Cancer Prevention Control and also the co-director of the Population Health Shared Resource within the University of Colorado Cancer Center. And so we've been doing some brief introductions to the different shared resources that are available. So I'm sort of like a bad entree into before getting to the main meal with Dr. Zimmaro, but I'll introduce you to the Population Health Shared Resource. And our primary mission with the Population Health Shared Resource is to support and accelerate the integration of population and behavioral health focused research across the University of Colorado Cancer Center. We have three specific aims, and one of them has to do with our curation of a large group of data sets that can be used for population-based cancer prevention control research. We also facilitate innovative and impactful population and behavioral cancer prevention and control research using qualitative and quantitative survey methods. And then overall, we want to support and promote the growth of in cancer prevention control and research across University of Colorado Cancer Center, but also supporting and collaborating with the other three programs, 2 basic science and 1 clinical science program. I co-lead this with my colleague, Dr. Marcelo Perrion, who is a health economist and biostatistician by training, and he oversees the population data science component of the Population Health Shared Resource, and I oversee the behavioral science side. We're very happy that we recently promoted Elizabeth Molina to be our PHSR manager, and we've gone through a hiring phase where we recently hired, and we'll start on June 15th, a new catchment data analysis to help us collaborate with the Community Outreach and Engagement Office. And then we also most recently, forgot to put his name, but Josh Pasek has joined us as one of our shared resource folks on the behavioral science side. One of the other things that we also do is to collaborate with Health Data Compass for individuals who have needs to take a look at the data in our electronic health record from the Cancer Center for our research purposes. UC Health will commonly provide those data for clinical purposes, but we actually work through Health Data Compass in order to fulfill requests for research data from our own electronic health record. This can help clinicians evaluate whether there's enough individuals in our system to conduct a clinical trial, or even identify individuals potentially for outreach to participate in trials. So that, as you might imagine, the population data science side has a lot to do with shepherding and curating those resources. And we're always interested in adding additional data resources to our repository, because not only do we curate those, but we have experience in analyzing them and can often help investigators conduct some really compelling health services research. That is, we have several examples of research that's been published in really high impact journals. On the behavioral science side, we look at more behavioral questions with regard to qualitative interviews, as well as surveys using REDCap and hard copies and other platforms in order to really facilitate knowledge collection and translation. But one of the other pieces that we do is we actually go into clinics to help clinicians and other investigators participate, collect and accrue individuals for human subjects research that is of a non-therapeutic nature. So non-therapeutic is a term that I really don't appreciate very much, but it's the one NCI uses. So we very much feel like some of our behavioral research is therapeutic in terms of improving quality of life and well-being, but it's not determined not to be therapeutic because it's not cytotoxic or designed to necessarily kill cancer cells. Here's some examples of some of the data resources that we hold and curate as part of our repository. You can see that we have established data use agreements with the Colorado Central Cancer Registry, lots of the Lung Cancer Screening Registry, lots of Medicare claims data, so you can see patterns of care. We also, as I said, work with Health Data Compass. And on a little bit more on the behavioral side, we have an experience working with the Behavioral Risk Factor Surveillance System, the Current Population Survey, and a number of other different surveys and softwares where we maintain expertise. Now, there is a boundary area. We do analyze a lot of data, but not clinical trials data or some of the where we really engage some of our biostatistical colleagues in the BBSR, as well as bioinformatics is managed by bioinformatics. As I mentioned, the behavioral science side includes qualitative research expertise, quantitative data collection and management, accrual and retention programming. And I think one of the newer things that we're doing is more project management, particularly for cancer prevention control research. And we're also up for anything else that you might have to throw at us in terms of ways to support cancer prevention control research at the University of Colorado Cancer Center. So I'm not going to take any questions right now, but if you have any, please feel free to email me or contact the Population Health Shared Resource on our website. And I'm going to go ahead and transition to my next responsibility, which is introducing Dr. Lauren Zimmaro. And I will allow our colleague to come over here and help with the IT logistics. But Dr. Zimmaro.
Actually, could you stay over here so the people on Zoom could hear you?
Oh, okay. So you move, I'll stay. So Dr. Zimmaro is a clinical health psychologist and is an assistant professor here in the Division of Medical Oncology. We're very happy to have recruited her out of her postdoc where she worked at Fox Chase Cancer Center and worked with some amazing scientists and colleagues there. Dr. Zimmaro initially got her bachelor's degree at Wake Forest University and then did her graduate training at the University of Louisville and then did her internship at Duke University, unfortunately, and then progressed toward her postdoc at Fox Chase. She does a really incredible work and that we're really excited to have her as part of the Cancer Prevention Control Program. Her work is in survivorship care for the most part, really helping individuals cope and transition to life following a diagnosis and maintaining quality of life and well-being using a whole host of interventions. Her KO7 award that's been funded by NCI or KO8, excuse me, is actually dedicated to addressing quality of life and well-being in couples who are experiencing colorectal cancer. So Dr. Zimmaro, we're really happy to have you here and look forward to your comments.
All right. Thank you very much, Jamie, Dr. Stutes, and thank you all for being here in person and folks online. As you mentioned, I'm Lauren Zimmaro. I'm a clinical psychologist and behavioral scientist here in the Division of Medical Oncology, and I will be talking about cancer distress and mindfulness today. No disclosures. So the agenda, it's a little comprehensive. I'm going to take some time to really hone down why we need mindfulness interventions. And that means I'm going to have to focus a bit on distress and why it's a problem that we pay attention to in cancer patients. And then, of course, giving you some basics on mindfulness and talking about the new ways in which mindfulness research is expanding to help fill some gaps in patient need. And then lastly, we're going to put all that together and I'll tell you about my new intervention I'm developing that kind of puts together all of those different frontiers. All right, so why do we care about distress? In 2023, there will be about 2 million new cases of cancer diagnosed. And for every 2 patients, one of them will report significant distress. And when I say distress here, I'm talking about anxiety and I'm talking about depression. Just easier to kind of group it all as distress. So this may not be a big surprise, that people are distressed, but I really want to put it into context here that this is a stark difference from the general population. This is information from the World Health Organization that shows the general population has about 4% of people with depressive symptoms or depressive disorder, compared to about 1/3 of patients who have been treated for diagnosed with cancer. And even more so is that difference with anxiety. So again, about 4% as compared to about half of folks. So not only is it common, but there are also a lot of different reasons why we can understand that patients would be distressed. When you're coping with cancer, you're dealing with medical and physical side effects, not only just navigating appointments, but dealing with pain, nausea, hair loss, weight gain, all sorts of new physical symptoms that one might not be used to coping with. Of course, you have your mental, psychological aspects of worry, fear, not only about yourselves, but maybe your family and your loved ones. Existential and spiritual crises are very common, and people tend to look towards those things as a way of coping. And then lastly, an interpersonal, social, or even a couples-based interaction here. These are all things, it speaks to kind of a wider network of why we see distress when coping with cancer. And over here on the right, you can see a list of just a handful of the distress symptoms that are typically assessed for as part of what's called the distress thermometer, which is part of the NCCN guidelines for managing distress in cancer. But overall, you can see it really touches on a wide range of symptoms, including those that are mental, physical, spiritual, and so forth. So I want to keep that just in mind for everyone too, about why mindfulness will be a good fit for distress, because kind of unlike other types of more typical psychotherapies where maybe they would just focus just on the mental piece or just on interpersonal relations, mindfulness is a way that can tap into all sorts of different domains, the existential domain, the physical domain, interpersonal, psychological, and so on. So although distress is typically highest in the first year of diagnosis, so right when people are getting diagnosed and beginning treatment, it's important to know that distress can persist for up to or even beyond a decade. So this is not something that typically goes away on its own. And if it does, it's going to show back up lately at some point. And even so, some of these more severe cases, yes, they will tend to get better, but the folks with moderate or more mild or even no symptoms of distress might later become so. So it's a problem that's not going away, and certain patients are at more risk for distress. Some here, there's sociodemographic risk factors that kind of speak to some disparities here. We've got younger folks, people with trauma history, low income, financial strain, low education, and people from communities that are marginalized or underserved, like LGBTQ or ethnic and racial minorities. And then on top of that, those can all intersect with certain cancer risk factors, advanced stage, if you're having more treatments or more side effects, so higher symptom burden, that's certainly going to be associated with more distress. And then also having a poor patient and provider relationship. So again, this is kind of tapping into the role of social support and an interpersonal nature that is really innate to navigating cancer. And if people have a good supportive relationship with their provider, it can help mitigate some of those risks. So that's all well and good. We know who's to kind of target and look for symptoms of distress. But it's important to do that because on the flip side, the people who are distressed are going to have worse psychosocial functioning, worse outcomes, worse quality of life, and worse physical health. So they might go home from their treatments. Oh, sorry, I'm just hitting things here. They go home from their treatments and their other, 23 hours of the day look pretty bad to them. Might have relationship difficulties. And also distress is linked to being less adherent to the cancer treatments and higher use and cost of medical care. And importantly here, it's not just the psychosocial side of things, but also the physiological and cancer outcome side of things as well. There's a whole host of literature that describes the physiological processes that go along with chronic distress. And I want to highlight here, this is more of the chronic or severe distress that can promote some of these pathways here. But all in all, when people are feeling a lot of distress, it's going to turn on all sorts of stress response pathways in the body that downstream can be linked to these hallmarks of tumor growth. Lots of citations there if you want to dig into that. That's not going to be a whole nother talk someday. But this was really fascinating to me when I first started to learn about coping with cancer. I was coming from more of a just traditional psych background and didn't really, I hadn't dipped my toes into the health psychology piece of it yet. So understanding that psychological symptoms can be linked to physiological outcomes or physical outcomes was really interesting to me, that mind-body pathway here. So one of my earliest papers here was looking at whether depressive symptoms were associated with shorter survival in head and neck cancer patients. And if so, is that because of biological factors? So maybe the tumor response to treatment, or was it accounted for by some of these behavioral factors? If somebody's depressed, it's harder to get out of bed. Maybe they're not showing up to their treatments as much, so it's not going to work as well. And that's because, we were really seeing a lot of interesting work coming out about this mind-body connection, but teasing apart the bio versus the behavioral reasons for it was still being explored. So here's just a quick snapshot of the measures and the folks we studied. So it was 134 patients that were just coming into their first treatment planning visit. So they have not gone through cancer treatment yet. I really need to stop hitting this, sorry. It's like right in my hands way. They hadn't started being treated yet. They might be early on in their disease trajectory, but this is important to keep in mind because it's the first time they're interfacing with their oncologist or with their clinician. So for the clinicians out there, they can kind of see how this would happen. So what we did the HADS to screen for depressive symptoms, and then we did a chart review. We looked at whether or not they had each person had a treatment interruption of more than a couple days, and whether after treatment the tumor had responded. So did it completely get treated, or was there going to be evidence of persistent disease, early recurrence, and so forth? And then, of course, measuring survival as well. So here we go. Depressive symptoms predicted shorter survival 2 years later. Okay, so this was crazy to me because this was first time they're walking into the clinic, more or less, and just symptoms at that point. For every unit increase on the HADS scale, they had a 13% higher likelihood of not surviving. And that was even after controlling for cancer stage. So independent of the typical predictors or of prognostic factors that we use to look at cancer survival, this aspect of distress and depression was really making a name for itself. And of course, you can see here the survival curve of people who had less depressive symptoms and those who did not. So then that second question of what possibly accounted for this. In fact, patients who were depressed, they did have more treatment interruptions. They did have worse tumor response to treatment, but the survival effects were only really accounted for by that treatment response. You can see here that patients who had no depression, they also had complete treatment response. So no deaths occurred among patients who had no depression. And that pattern continues though, when you have people still with complete treatment response, the patients who were depressed or had some sort of depressive symptoms did die sooner. And then the same for poor treatment response. And there's a little switcheroo there at the end in this graph, but you get the overall pattern was pretty much the same. So this is really speaking to kind of that mind-body effect again, that there is some sort of biological disruption rather than behavior-focused reasons that could be associated with tumor progression. So we need to pay attention to and intervene on even mild symptoms of distress early in the cancer care. But unfortunately, distress, like some other kind of Well, like sexual health, for example, I'd say distress and sexual health are actually both pretty under discussed in medical oncology visits. And I'll just real briefly go into a quick qualitative analysis that I did recently, looking at how often distress was discussed, and whether that was related to how bad the symptoms were for the patient. And we audio recorded, transcribed, and coded 134 outpatient clinic visits in a breast oncology clinic. We coded them, meaning we looked through the transcripts to find any instance in which the patient, the provider are talking about mood symptoms. So did it happen? What was the context around it? The patients also completed a survey about what their distress symptoms were. Did they have any, and how severe? So on that self-report, over half of the patients did report that they had distress. On the other hand, only 19% of them discussed this with their provider. And the folks who did discuss it, they were younger women, women with metastatic disease. Here's one sample quote. It says, "My problem is every time I get an ache and a pain, I'm thinking the cancer went someplace else. It's a lot with the mental. It's the mental part that scares me. I'm constantly worried." And then in a younger patient, she said, "I was doing great, and then I think just emotions all over. I don't know why, but anxiety sometimes, feeling down sometimes, crying sometimes, no patience, getting irritated with my family." So although distress wasn't discussed as much or in line with the number of patients that were endorsing these symptoms, it was promising that the patients who had more moderate and severe symptoms did talk about it more. Although, of course, it does leave a gap here of where there's still mild symptoms. Those were kind of getting missed. I won't go through this whole chart now, but I thought it was really fascinating to see what those discussions looked like. Were they talking about mindfulness? Were they talking about ways to treat distress and to cope? And the conversations typically went that the patient was describing some sort of distress, as we saw. The provider went and dove into this a little bit with them to try to understand what was the context around it, and then offered interventions. A lot of it was psychotropic medication, but a lot of the physicians or clinicians had a whole toolbox of coping that they offered to their patients as well. And I will note that this, of course, is in a comprehensive cancer center, a step box chase, so these resources were readily available. It would be very interesting to see what this would look like in a cancer center or more of a primary care setting. So one key point here is that, yes, medications can work very well for distress. If you're distressed, just take your SSRI and it'll be better. Maybe. In cancer patients, that's not always the case. And so it really highlights that behavioral therapies, different types of psychosocial therapies are needed to help them cope, especially that we know that these types of symptoms can persist for many years to come. So equipping them with skills is going to be key. And this is where our mindfulness comes in. So who here has heard of mindfulness? Yay, almost everyone. Okay, great. It's become quite the thing. So mindfulness, it's the practice of focusing your attention and awareness on present moment experiences, including the thoughts you have, the emotions you're feeling, physical sensations in the body. It's simply noticing what you observe calmly and without judgment. I think of it almost like being an outside observer, looking at yourself, looking within yourself. What are the thoughts that are going through your mind? What does your hand actually feel like? What do you notice? And so when we measure mindfulness in validated measures, I wanted to give some examples of the items that people are responding to. So first one, when I have distressing thoughts or images, I'm able just to notice them. without reacting. Or I think some of my emotions are bad or inappropriate. I shouldn't feel them. When I do things, my mind wanders off and I'm easily distracted. And so in thinking about cancer and the application here, you can kind of realize that, some of these words, when I have distressing thoughts or images, just notice them without reacting. They might be thinking about distressing thoughts around their treatment or even their prognosis. Emotions that are bad, like, oh, this is where the toxic positivity can come in. Like if a patient might be thinking, man, I'm really scared or really sad. Oh, I shouldn't feel that way. I need to stay positive. That is not necessarily mindful. What we would say instead to be mindful is just to acknowledge the presence of that negative emotion, of that negative experience, witness it, and just let it be. So there are multiple kind of factors or facets of mindfulness when we think of it. And this is part of a measure called the 5-facet mindfulness questionnaire that I use in my work. And the first aspect here is observing. So again, this is just simply noticing what's there, paying attention, acknowledging. Whoops, where are we? Second, being fully attentive to your behaviors in the moment. So I don't know about any of you, but sometimes driving home, you get home, you're like, wow, I don't even really remember driving because my mind was kind of off somewhere else. That's our autopilot, very common. It's okay, but it's not necessarily the most mindful moment. Non-reactivity. Oh, sorry, everyone, I'm pressing the wrong directions here. Non-reactivity. This is, again, allowing the thoughts, allowing your sensations to come and go and not getting carried away down with them. Our mind can tell very compelling and interesting stories that are full of drama and whatnot, but we don't always have to believe what we think. And this kind of gets at that there. Similarly with non-judgment, we tend to have a commentary in our minds about others and about ourselves. I shouldn't feel this way, or that was a helpful thought. Things like that. You're usually assigning positive or negative value to your experience. Non-judgment is taking that away, just noticing it, kind of being super objective. And then lastly, being able to describe or labeling what those experiences are. And just real quick for just kind of clarification here, mindfulness, meditation, relaxation, they all overlap. You can do a mindfulness meditation. You can be relaxed while you meditate, but they are separate in that sometimes when people are being mindful, it's not that relaxing. It can actually be challenging at first. You might start to notice or say things to yourself like, oh, I'm terrible at this. I can't meditate. Or you find yourself easily distracted and enter all of those judgments, right? And that's okay. That's just part of it. It kind of speaks to this well-known fact that observing is kind of the first skill that people learn. But as they practice over time, that's when we see the non-reactivity and the non-judgment really starting to show themselves. So that makes sense a little bit. Oh. All right. So we know that these types of mindfulness, so mindfulness, first of all, is a skill that you can learn. Some people are born with being more mindful, and other people need to learn and practice over time. I'd say most of us are there. There are many different types of mindfulness-based interventions, of course, starting with mindfulness-based stress reduction, which was the seminal program made by Jon Kabat-Zinn. And since then, there have been developed several others, including the mindfulness-based cancer recovery and mindfulness-based cognitive therapy for depression recurrence. And these all have shown small to medium effect sizes, as you can see here. But I want to highlight that one of the formats known for these programs is that they tend to be group-based, in person, and there's 8 weeks long for 2.5 hours per session plus a full day meditation at the end. So if you have advanced cancer, if you're in current treatment, if you are sick, a lot of that is going to be off the table for you. It can be really burdensome for people to attend, excuse me, and to make use of this sort of tool. So this is where the drawback is. There's some drawbacks in these standard MBIs that leave key gaps in knowledge and therefore in patient care. And this is what I'll be focusing on. It's kind of this new frontier I'm talking about in mindfulness. Specifically, patients with metastatic disease, they have more or less been excluded from clinical trials around mindfulness-based interventions. You can go to literature, you're like, where are all of the stage 4 folks? Feels like they would probably be the ones to really need it, given that it helps with coping. Mindfulness can help really savor the present moment. And when you're faced with a terminal illness or a poor prognosis, what's more important than the time you have? Second is a focus on kind of like specific cancer symptoms. And I'll be talking about body compassion around that. So specificity towards cancer, an interpersonal context here. So including not just the patient, but the partner as well, who we know very consistently report higher distress than the patients themselves. And then lastly, along those lines, is sexual function and intimacy. All of these areas either highlight people who are in need, so it's patients with metastatic disease, the caregiver or spouse, or it's highlighting an area of cancer coping that needs attention, the physical body and intimacy or sexual function. So let's start with metastatic. So as I said, patients with metastatic disease, there was very little out there of what mindfulness looks like for them. And so I was really lucky to get to work with Laura Porter and others down at Duke Cancer Center during my internship to analyze the baseline data from their yoga trial in women with metastatic breast cancer to see what aspects of mindfulness, if any, are associated with better quality of life, better functioning in those women. In other words, does mindfulness do all the things we see it do in less advanced cancer? Does that apply to metastatic as well? So just here's a little snapshot of the women that were in this trial, 64 women. They completed surveys on distress, pain, fatigue, sleep. And when we looked at the relationship, we saw that, of course, as one would have thought, higher mindfulness was associated with less severe symptoms of distress, of pain, of fatigue, and of sleep. And most importantly, there it was again on that non-reactivity and non-judgment. They were across the board the most highly correlated with those outcomes. So what might be the most or a particularly valuable skill when you have metastatic cancer and you're dealing with and you're trying to work with mindfulness? It's probably focusing on this non-reactivity and non-judgment piece, allowing and accepting the present moment as it is. And still there's a lot of work that needs to be done in taking a closer look around metastatic patients or advanced cancer patients when it comes to mindfulness to better understand how it works, what's needed. So let's move on to this next aspect here, which is body compassion, which is one of my key areas of focus. So what is body compassion? This is different from self-compassion, okay? It's not on the slide, but self-compassion is kind of more of the holistic view of compassion towards yourself. Think of like self-care and, be nice to yourself, be kind to yourself when you're experiencing certain difficulties, emotions, and so forth. Body compassion is very specific to one's physical body. It's regarding your own body in its appearance, its confidence, its health, its function, with a sense of mindful awareness, with kindness, with awareness or recognition of the common human nature of having a physical body. We're all in the same boat with our bodies in a way. So it's almost like seeing your physical body as a separate entity, as the self. Takes a little while to kind of like work with that thought, but again, it's taking our kind of our psychological side of ourselves and our physical selves and separating them so we can take a new perspective around our physical body. The body compassion scale has 3 different subscales, including acceptance. So accepting the body. I feel okay in my body, for example. Common humanity. When I'm at my lowest during times of illness, I know I'm not alone. And diffusion. So this is getting at that diffusing or separating the mind and the body. When my body isn't responding the way I want it to, I tend to be tough on myself. That's not body compassion, by the way. That would be reverse scored. So in thinking about this, why would this be important to cancer? And several reasons, I'm sure I could come up with others, but some key ones here is if you can build a sense of connection and compassion towards your physical body, it can help you feel more meaning, more resilience, and perhaps promote more self-care health behaviors, exercise, nutrition. So taking better care of your physical body as if it were a good friend of yours or a child or a loved one. Recognizing that physical experiences, including cancer, are part of the shared human condition. This could be powerful in combating stigma, especially with cancers that are linked with a stigma, a sense of loneliness or isolation. And then lastly, acknowledging and appreciating the body's efforts for fighting the cancer. So that would shift us away from self-blame, perhaps falser sense of gratitude. You know, the body's really going through a lot when it's going through treatment. It's really being put through the ringer. And so one can feel down on yourself if you're tired and fatigued and you just feel like bad a lot. You know, if you're able to have compassion, like, hey, my body's doing the best it can to fight this, it softens that feeling a little bit of distress. So this whole sense of body compassion has not been studied in cancer yet, despite all of those reasons that I think it should. So I was lucky to be able to put it into one of my pre-pilot studies on distress in a colorectal cancer sample, who did so this was 34 patients, again, back at Fox Chase. They completed psychosocial surveys on their psychological health, resilience, coping, and 12 patients also gave a blood sample to look at inflammatory markers. Those patients were not currently in treatment. And here are some of the measures that we took. And there were no other associations, demographic, clinical features, but males did indicate more mindfulness, and patients with rectal cancer also indicated more mindfulness. So I need to do some thinking on those. But overall, controlling for partnered status, metastatic disease, whether or not they were current treatment, we did see that patients who had higher body compassion had significantly less distress, significantly more resilience, and better quality of life overall. So this is a really promising avenue. And what was also really cool was that when I did a mediation analysis to say, hey, you know, mindfulness and body compassion are they're related. The correlation, I think, was like 0.3 or 0.4. Does body compassion account for the effects of mindfulness on having low distress? And, oops, here we go. So yes, more mindfulness, less distress. More mindfulness, more body compassion, less distress. And when you put that all in the model, the relationship between mindfulness and distress goes away, meaning that body compassion, feeling compassion towards your physical body after colorectal cancer could really be a driver here around coping with distress. And so interventions might really want to start paying attention to that specific skill in coping with cancer to help alleviate the distress. And this just came in, our assay results just came in on Friday. And so I really quickly threw this slide together. So I apologize, it's not so cute. But it was really fascinating because I mentioned there were 12 patients that gave us a blood sample. And body compassion did seem to co-vary with certain cytokines, tumor-relevant, inflammatory, and anti-inflammatory markers. Now, I need somebody who knows a lot more about cytokines and inflammation to help me make sense of all of this. But we do see that, for example, higher body compassion was associated with lower IL-6, which is a typical pro-inflammatory cytokine, as well as several other cytokines here. I should say, these are the subscales of body compassion here on the left. At the bottom, you'll see our assay lineup. So more to come, and I welcome any thoughts or people who want to kind of dig into this a little bit more with me. All right. So an important thing also to know here is that body compassion can ebb and flow or differentiate based on cancer relevant factors, including whether somebody's in current treatment and whether they are diagnosed with advanced disease, with body compassion being lower in both those instances. So it's a real opportunity to kind of target either people who are going through treatment or people who have metastatic disease, to target and intervene on body compassion as a way to help them adjust better to the cancer journey and reduce their distress. Now, of course, we have to do some clinical trials to be able to say all of this for certain, but I am gathering some more data in other cancer types to see if this is the same kind of pattern that we see. But I do hope that this shows that there is at least a really positive signal here that we should be paying attention to compassion towards the physical body as a potential avenue to help patients cope better, that could potentially be related to inflammatory or processes related to health outcomes. So stay tuned for more on that. All right, how am I doing on time? I think we're good. Okay, any questions about that before I move on to the next one? Yes.
So the last slide you had
Oops. This one.
Yeah, so did you also do the cytokine analysis there, or planning to do, or this?
Sorry, say it again.
Cytokines.
Right.
You do any cytokines there?
So the patients who were in treatment did not give a blood sample because it would be messy. I don't believe, I don't think anyone therefore had metastatic disease who also gave a blood sample as well. I can double check that, but they would have been in active treatment. So yeah. Yeah, it's tough because, you want to control for things with the blood samples. So, but we only have 12, but I'm really excited to keep looking and see what else we can find. Thank you. All right, so moving on to interpersonal mindfulness. So I mentioned before that mindfulness, actually didn't mention this, but mindfulness is typically thought of as very individual, solitary practice. You might be sitting alone, meditating, or you're washing the dishes and being very mindful as you wash your dishes. It's a solitary experience, but it doesn't mean that it can't be applied in an interpersonal context as well. And so what is this concept of interpersonal mindfulness? It's being mindful within your interpersonal interactions. So being aware, attentive, accepting, and responsive, not only to yourself in our typical mindfulness sense, but also kind of having 50% of your attention also on the other person. So it's broadening out your mindful awareness to kind of this next sphere of awareness. And in thinking about example items here on the scale, the interpersonal mindfulness scale, here's some examples here. Being fully engaged in the conversation, being aware of my own facial and body expressions when interacting with others, listening to another person without judging or criticizing them. And excuse me, when I was recently presenting this data, somebody brought up the really interesting point that interpersonal mindfulness on the surface might seem like it could overlap with like hypervigilance in a social setting. So being very attuned to another person, what they're thinking, feeling, doing, maybe overlapping with social anxiety in a way. But that's why I want to highlight that it's not having 100% of your attention on the other. It's having more or less an equal balance on attention to them and yourself. Again, without that judgmental piece. So why would this matter? Relationships are important in coping with cancer. They can really be a source of resilience and better adjustment. So being interpersonally mindful within those relationships could help improve relationship quality, perhaps, cancer adjustment, perhaps. And this doesn't just apply, I think, to relationships between, let's say, spouses or partners. This could also apply to the relationship between the patient and the provider, which, if you remember all the way back in the beginning, that relationship is really important for also coping with distress. So there's multiple different places we could think about this being important. Second, relationships, although their source of resilience, can also be strained when dealing with cancer. So this could be a skill to help kind of navigate that relationship stress and perhaps helping specifically with communication. So when we're interpersonally mindful, we're often having a conversation. So using specific interpersonal mindfulness skills during communication, I wonder if that would help people navigate all those difficult discussions that happen. But again, we need research, right? So this is another example of how this has not really been looked at in the context of cancer yet. It has mainly been in teaching settings, so interpersonal mindful with teaching or with parent and child interactions. So I looked at this again in that sample of colorectal cancer patients, and higher interpersonal mindfulness, again, is linked to all sorts of good stuff: less distress, more mindfulness, better quality of life. It was not associated with loneliness, though. I was like, oh, that would have made so much sense. But loneliness is a sense of being alone. It doesn't matter actually how many friends or people you have around you. It is whether or not you perceive them to be there, to be supportive. And so in that sense, interpersonal mindfulness might not apply to that perception because it needs you to actually be interacting with those people. You can interact with people, but still feel lonely. And then here is, again, hot off the press by our cytokine results here. And it was really similar patterns. If you can remember what the other graph looked like, it was very similar to this. Higher interpersonal mindfulness had a positive correlation with GM-CSF, IL-1 beta, IL-2, and IFN gamma, and then also with lower IL-6. So more to be done, but it's just a little teaser here that we're seeing some really promising signals that this type of skill can be also potentially reflected in physiological stress pathways as well, in a good way. So again, this is a journey we should certainly lean into. It could be a promising skill. We need more research, and I am including this in my KO8, which we'll talk about shortly. And I'm going to hustle up a little bit here and talk about our last gap and new extension for mindfulness, and that is for sexual function. When we think about sexual function, sexual intimacy, it's hard pressed to think of something that isn't more mind, body, and also interpersonal. So it's a great context to be thinking about a new application for mindfulness. And cancer-related sexual dysfunction is not only common, It's highly distressing, and it doesn't go away without intervention. So there's a whole host of different types of effective interventions, some more so than others. But we wonder, again, could mindfulness be another opportunity to give patients a tool to help navigate sexual dysfunction after cancer? And so I'm doing a literature review right now with colleagues Steve Lepore and Jennifer Reese in seeing what's out there. Do we have evidence that this, again, is there a signal that mindfulness might be a unique application that's worthy of developing more in cancer? And here's our inclusion criteria for that review. Found 13 trials, which I was surprised it was more than I thought, that looked at the effects of a mindfulness-based intervention for sexual function in people with cancer. And I know you can't see this very well, so sorry, I added it last minute, but I wanted to highlight that every single trial, except for one, which was a dissertation, and it actually didn't have a sexual function outcome, it just had a sexual distress outcome, so that's my little asterisk. But other than that, every trial showed evidence that either pre to post or as compared to a control group, that practicing mindfulness skills did help alleviate sexual function issues. And that was, there were a lot of breast cancer patients here. So we think of kind of genital type symptoms, orgasmic issues. Again, that could be for, we've got prostate cancer in here. So is that it? We've got prostate, gyne, breast, a couple different types of cancer here. So across those, we are seeing a positive signal that this could be a really useful skill. But of course, there were a lot of different variations in the types of trials and the types of interventions, such that the randomized trials tend to be more of those mindfulness-based stress reduction, those longer 8-week interventions, whereas the blue half here at the bottom are more abbreviated, targeted 4-week, for example, interventions that were specifically teaching mindfulness skills for sexual function. Either way, things looked good, but there's varying quality and so forth. So we'll have to see what comes next. But this was really exciting for me to see all this. And it was actually cool for me to put this presentation together to really see how the puzzle pieces were fitting. And that when we put all of these new applications to mindfulness together, it led me to what I'm working on now, which is my K08 in developing a new mindfulness-based couples intervention for people with metastatic colorectal cancer. So just a brief overview of my trial. Right now, we are in this AIM-1 development phase of creating this intervention. It will involve interviewing 12 couples, 12 clinicians to get a better understanding of the needs and preferences, thoughts of mindfulness in this population, drafting up my protocol, and then running it through experts, and then another set of patient couples to see if it was up to par, I guess. And then second is that randomized trial that I will be doing, 45 couples, a randomized control trial. So there are aims. That one will be to look at the feasibility and acceptability of it. So as I mentioned, we're doing this qualitative phase right now. We just started recruiting. So thank you to Josh, who mentioned before, to helping get this launched. It's going to be a really interesting way to kind of dig into and get a better sense of what patients think of those kind of 4 different areas we've been talking about so far. And the last thing I want to wrap up with is just a sneak peek again of what I'm hoping this intervention will look like. So in order to kind of combat that high burden, we're going to do 4 sessions, all over Zoom. They'll be couples-based, so both the patient with metastatic disease and their spouse or partner will be on a call. We're going to have a mindfulness-based theme for each session. So awareness, for example, learning skills of building awareness of the self and the other, acceptance, so being willing to experience without judgment, reactivity, any sort of discomfort that's related to the cancer. And then compassion, of course, not only for yourself, the physical body, but compassion for your partner. And then rounding things out with connection at the end. And so this is where we would apply some more of those principles of intimacy, mindful touching, sensate focus type skills. All right, so that was a lot of data, and I feel like I went through it really quickly, but I'm very grateful for everyone being here. And just to sum up, developing innovative approaches to alleviate cancer-related distress remains a top clinical, top research priority. And mindfulness-based interventions are continuously advancing, forging new paths to meet this demand and enhance the well-being of people affected by cancer. So thank you for learning about all of that with me today, and lots of acknowledgements here, including mentors and the PHSR too at here at Colorado, and then the external team as well. So, and the funding sources. Thank you, NIH. Thank you very much. We have a minute and a half, and I'm happy to take questions. Or you can also email me, which I can put up here. Yes, please.
So in my opinion, curious if the presence of family, like whether, you know, the patient family members are close or bigger family, was that dynamic looked at? I guess the reason why I'm asking is because consistently throughout the talk, sense of community kind of seemed to be like in the backdrop.
Yeah, like a context.
Yeah, so you seem to have like better outcomes if there were aspects that led to a greater sense of community.
So,
in my mind. So I'm wondering if like the presence of family or the interactions with the family also helped with that mindfulness and consequently help with the outcomes.
the outcomes, great. Yeah, so the question was, see if we can summarize those. Question was, did we look at a sense of community or family relationships, dynamics within the family, or a sense of community to help maybe explain or supplement our understanding of interpersonal mindfulness? And the short answer to that is no. Family or having a close social network can certainly account for better coping. And so I think that's a great idea to kind of start to measure that as well, like social support or family interpersonal relationship type dynamics to see if that overlaps with interpersonal mindfulness. Yeah, it's a good question. Yeah, please. Oh, thanks.
I noticed you're doing for plan.
Yes.
I guess I'm doing kind of like solution.
Yeah.
You have a resources here, but you don't have all of this. So I'm wondering if it's as effective in these types of connections. Probably as a person.
Yes, that's a great question. Just to repeat, she was wondering whether there was evidence that telehealth-based mindfulness interventions are just as effective as in person. And if I'm remembering correctly, yes, that there really isn't a big difference between the modes of delivery. However, your other point of, you know, what resources are available, like, are you coming from a cancer center that has a lot of support opportunities, or where this is more likely to be disseminated? It's certainly something I'm aware of. And I've grappled with this whole aspect of mindfulness kind of being a upper class white woman thing for a long time, kind of along with yoga. And there really is a need to be able to kind of chop down that that reputation, because it's highly applicable and actually very well received if the language is appropriate to other communities. So I hope to include more resources, like a resource handout and something like that to the patients, and to recruit from areas that are not directly, Denver metro, but from more rural to get a sense of the feasibility and acceptability there. Does that answer your question, sort of? Yeah, thanks. Cool. All right, everyone, meditate later today mindfully, and thank you for joining.